Hello, thank you for that talk. My name's Dan, matron in Nottingham for acute deterioration improvement. I appreciate you talking through some of the national challenges. I think for me, step one is usually to try and understand the problem as well as possible, and that includes understanding that national data. And I appreciate the fact that you've also described some level of confusion with understanding what that means and how it's measured. I think for me, from my perspective, we rely quite heavily on coded data for understanding some of these issues, and I don't need to describe to everyone in the room the limitations of coded data. So I just wonder, from a national perspective, is there a plan to try and improve that sort of primary measurement that we can actually use to help us to have a starting point for making some of these improvements?
Thank you, Dan. Really, really great question. And the answer is yes. So coded data is really helpful in that. So I think what you mean from that is the stuff that goes into hospital episode statistics. Your coders sit in a basement somewhere, certainly used to be the way, sit in a basement, a dark room somewhere, trying to work out from the clinical notes which OPCS codes fit the patient's profile and so on. That's really helpful when it comes to the big numbers, because we do need that, and we need it to... one of the ways in which it's really particularly helpful is that it's unbiased insofar as it's collected on every single patient. But if we're going to make these changes a reality, then we're going to need something that's a bit more like a national clinical audit that looks at not just the outcomes, but the processes of care. So things like, are they getting the right antibiotics on time? And really importantly, I didn't even mention, to my shame, the parallel AMR, antimicrobial resistance, antimicrobial stewardship challenge. So it's not just about dousing the patient in antibiotics quickly, but it's about appropriate de-escalation and all those sorts of things as well. So we measure the counterpoint, and we don't inadvertently breed bad behaviours by incentivising in one way or another rapid antibiotics, rapid this, rapid that. So yes, there's a plan. Can't be too clear on what it is yet, but there's definitely a plan.
Thank you. And I can also say that UKHSA, we're working on trying to develop a national surveillance programme. But obviously the coding, if it's rubbish in, rubbish out. Yep. So hopefully that gets better. We'll take one more question.
I'm Dee Waterhouse, I work for Health Innovation Manchester. Loved your presentation, and obviously very interested in the innovation element. And I noticed in your last slide you put in about AI. And we know it's a bit of a minefield out there with all sorts of elements going on in the governance. How do you see that sitting in the modern service framework, and what governance is going to be around that? Because it is a minefield out there. And I don't know if that's too big a question.
No, it's not. I mean, I suppose the governance around deployment, Kira's probably better expert to talk about this than I am, but the governance around the deployment of AI tools is a really live topic everywhere. I think, and innovations such as the one that's been described, where there's a bit more transparency about what's inside the black boxes, are really helpful. So I think AI in general, there's a governance approach that we have to take for it. AI presents us with lots of opportunities when it comes to sepsis, because, for example, if we are going to move forward with things like prediction of people who are likely to move from just having an infection to being septic to having, having advanced organ failure, for example, then incorporating all of the data that we can get, not just from clinical data of the type that Kira's team have been analysing, but also omics and stuff like that, that we haven't really got deployed in a big way yet. There's the opportunity, right, for AI. But it has to be done in accordance with really good clinical governance. And I'd say one other thing, which is, I think we have to not get too excited and run away with the AI thing. I think there are approaches like the one that we've heard about, where it's doing something really novel because it's using continuous data, it's doing stuff in near real time. That's really, really super innovative and helpful. A straightforward prediction model, like, the KERB65 for pneumonia or whatever for whatever else, I want to see the AI model that beats those simple things first, validated in an appropriate setting. So not just in one place, but across the board. And actually, when it comes to things like that, just better implementation of simple stuff we could move a lot further forward. And there's going to be a big focus in the MSF of not just doing all the super exciting, sexy things, but supporting clinicians, managers, everyone to do better on the simple stuff. So, for example, emergency laparotomy for sepsis, we measure the sepsis metrics through the National Emergency Laparotomy Audit. They've improved pretty much everything else in the audit, including mortality. But movement on the key sepsis markers, like timeliness of antibiotics and so on, has been almost zero in 10 years. So that's not fancy AI or fancy this or fancy that. That's just clinical implementation of best practice, better, faster. And so kind of QI approaches, which again, Health Innovation Networks support us with, that's the kind of thing that we'll be looking to do as well.
Hiya, sorry, I'm Emma from Coventry Hospital. Really interesting talk about the implementation and the data that you're getting from all these hospitals. We've gone from paper to electronic in the last 2 years, and everything's gone into meltdown, I think, in our hospital. And coding, as the gentleman at the front was mentioning, has gone down, so everything's just going a little bit wry. But I'm curious about you having all this data. Is there anything that's spurious that's come off it and you thought, well, I didn't expect that? And are you going to be feeding those differences into NICE guidance that's there? And will that NICE guidance that's there for NG253 support what you're finding?
Yeah, I think, first of all, can completely sympathise, having worked with two different trusts, one who moved from paper to Cerner and one moved from paper to Epic. You're absolutely right. We could see it immediately in the data, and we were getting all sorts of spurious findings. And that was why it was key for us to sit with our quality improvement teams to understand, actually, this is just an anomaly of somebody using the wrong form at this time, and actually we need to kind of standardise processes as we're going along. To put that in context, for about 18 months in the trust that moved over from Epic, we didn't use any of the data. We just went back to the data warehousing folk and did it the old-fashioned way, because the stuff that was coming out of Epic was just all over the place, and it needed that bedding in period. So, I mean, that's just real world, right? And it's messy data, and we have to deal with that. What did come out of it that was beneficial was that feedback from us to the team to say, oh, okay, this looks really like, this looks like an anomaly, and they would explain why, and then quality of the data input would improve. Probably the most striking thing in terms of something we found that then sped off was our digital sepsis alert was amended and was really good for detecting COVID patients. So we were able to deploy that quite quickly when the pandemic came, because we were kind of ahead of the game and could see in the data, oh wow, alerting is going through the roof, and it was all the COVID patients, right? So that kind of fueled our research in that way, I guess in a kind of positive way. Anything that's come out, so I haven't put my publications up, but there is a publication that goes into a lot more detail about that stratified analysis that we did. So the fact that these alerts are working differently in different patient sub-cohorts in hospitals, and that's something that we're responding to as part of the NICE guidelines as a team. So hopefully that gets taken into account, and it kind of ties in with the last speaker as well.
I'm Anu Rajgopal. I'm one of the microbiologists from Collider in Huddersfield. Thank you for a lovely talk. I was just wondering, we moved to EPR Cerner in 2017. In any of the data that you've received, has there been any look into patients who are either penicillin allergic or have an EPR alert with resistant organisms and their mortality in sepsis? Is there a subset that you've looked at?
There is, and we're writing a paper on this. Can I chat to you a bit later? Because I'd like to pull up some of the figures that we have and maybe talk them through with you. But yeah, that's absolutely work that we're doing in collaboration with all of the sites, looking at penicillin allergies, yeah.